Hi, everybody. It's Dr. Carrie Reller, your family and obesity medicine physician in Clearwater, Florida. I'm here today to talk to you about obesity and asthma. So obesity is a disease, as I've mentioned in previous lectures, and we're not going to go into the details of that part today. You can see the other video on that if you need to. How do I get to the next slide? Okay, so the prevalence of obesity and asthma. So the prevalence of the two in general separately are increasing in the world today. That's both adult and pediatric populations, and they're both strongly correlated epidemiologically, but correlation does not mean causation. So that means they may have things that are associated with one another, but that doesn't mean that asthma directly causes obesity or obesity directly causes asthma. So excessive weight is associated with the increased incidence of asthma. So for people who are overweight, which is a BMI of 25 to 29.9, there's a 38% increased incidence of asthma. And those who have obesity with the BMI greater than 30 have a 92% increased incidence of asthma. Obesity is actually linked to 250,000 new asthma cases a year in the United States. So during this whole research and discovery, there's different asthma phenotypes that have been developed because they have different characteristics. They have different presentations, how they present to the, clinically. And they even have different treatment responses compared to with traditionally described asthma. So patients with asthma and obesity, they usually have a more severe form of asthma. They have more exacerbations, more hospitalizations, and poorer symptom control. They also have reduced quality of life scores. They don't respond as well to the recommended standard, like inhaled corticosteroids that we use to normal weight individuals. And then some are showing this trend toward neutrophilic inflammation. So neutrophil is a different kind of white blood cell, and it's a different kind of traditional inflammation that we see in typical asthma, and it's also harder to control. So basically, we need more new therapies to be discovered in this area, and that's why it's super important. So there are many mechanisms for association between the two. And remember, association and correlation are not causation. But first, I'm going to go through the airway mechanics. So basically, there's lung volumes that are different. There's also alterations in smooth muscle, and that also has to do with lung volumes. Then there's systemic inflammation and non-eosinophilic airway inflammation. We'll go into that, as well as insulin resistance, asthma treatments. I'm not going to go too far into comorbid conditions, vitamin D deficiency, or any genetic tendencies, but I did want to mention those here as basically they can be associated with the two. So the difference in lung volume. So if you can see on the left, there's the lung volumes of a lean person. You can see that the boxes of lung capacity differ to the lung volumes in someone with obesity. So the total lung capacity is decreased in someone with obesity. Okay, so keep in mind these things. So basically, when we look at the breathing tests of an individual, they kind of are assessing those lung volumes. So every time you come into the office and we say, hey, let's do a breathing test, we're kind of looking at the amount you exhale in 1 second. So typically with obesity and asthma, you're either going to have a normal value of that, or it could even be increased. But these other lung volumes are different in obesity and asthma. And an overall picture, instead of being in a totally obstructive pattern like you see in traditional asthma, there's also restrictive pattern of lung disease, which doesn't, respond as much to something like albuterol, which is supposed to dilate those airways. Restrictive lung disease is harder to manage. So not only are the lung volumes different, but the actual smooth muscle cells that exist in those bronchial airways are different. So the small airways in the lungs, they need to dilate and expand and contract depending upon what's going on. And with the lung volume reduction overall, it decreases the ability of those small airways to expand. And it also reduces the stretching more even at the cellular level of those airway smooth muscle cells. So those smooth muscle cells become hypercontractile. That means they want to be really tight and constrict. And that means that air is harder to get through those smaller vessels, right? The increased airflow obstruction, basically the hole that's open gets tighter and you can't get the air through as well. And then also the airway becomes more hyper responsive. That means it's more sensitive to things that may bother it, maybe a chemical or allergen or anything else like that. So those are definitely negative effects that occur when you see asthma and obesity together. And then there's this thing called nitric oxide. So we used to use this in the office. It was a little cloud test that you would exhale and try to, we would calculate how much exhaled nitric oxide was there. And that's usually a good marker of eosinophilic inflammation. And that's what a traditional asthma has seen. So if you have, a very, very allergic asthma, we may see those increased eosinophils. Those ones are what we call a Th1, 2 pathway. So the nitric oxide is something that's really important in the regulation of the airway tone and the responsiveness. So it helps, those bronchioles dilate and everything. In obesity and metabolic syndrome, the nitric oxide metabolism has been reported to be abnormal. So because that's abnormal, it's, harder for those smooth muscle cells to dilate, kind of like how I was saying before. And actually, instead of in obesity and asthma, instead of getting those increased sputum eosinophils, it's becoming to be increased sputum neutrophils, which is once again a different type of asthma that I'm going to talk about soon, but it's harder to treat. So another thing, there's physical forces from obesity, right? That like a BMI of 40 or 50 has this extra adipose tissue or fat tissue in the chest that can also alter the mechanics of the breathing. It can weigh down the lungs, basically causes increased resistance in the lungs and make it, even harder to breathe. So obesity ends up resulting in rapid shallow breathing instead of, those full deep breaths. And if you're not getting full deep breaths, sometimes those smaller airways at the bottom can close up. And that's what we call like airway collapse or atelectasis. They often report that on chest x-ray results if you've ever read your own chest x-ray before and had that. And then once again, I mentioned they had decreased lung volumes. That's what those ERV and FRC, those are different lung volumes. So obesity results in the shallow breathing, and it also, like I said, can reduce that peripheral airway diameter. So those end bronchioles that you would, those are usually the first to go in traditional asthma, like when you're having an exacerbation. So obesity is already causing impairment in that. And then it leads to that increased airway hyperresponsiveness. And then this is pretty amazing, and I wasn't even aware of this, but obesity can also cause increased adipose tissue or fat tissue actually within the walls of the airway. So I had a pathologic slide from a study that I saw that shows that there's fat cells in the airway. So obviously that could be blocking, and causing obstructive a pattern as well for breathing. So basically in previous topics, I had discussed about how there is this sick fat disease or the adipose tissue dysfunction. And one of the things that adipose tissue does is give off all these inflammatory markers. And in this slide, the important ones are related to asthma are TNF alpha, but most of all that IL-6. So that's interleukin 6. And asthma itself is an inflammatory disease and has all these other inflammatory markers going on as well. So now we're talking about two inflammatory diseases together. Not a good recipe. So this is the different inflammatory markers in asthma. Don't be overwhelmed by this slide. Don't worry about it. But like I was saying before, that for that type 2 inflammation where, you know, you're having allergy, or an allergy antigen comes in and it, you know, activates all these different things in the cell. So there's IL-13, IL-4, IL-5, and a lot of the new fancy asthma medicines are focusing on these crazy inflammatory markers that kind of reduce the eosinophils in the blood or in the lungs too. Okay. And then if you know montelukast or Singulair, that blocks these leukotrienes that are developing there. And then Xolair blocks this IgE over here. So we got all sorts of drugs that are acting on these parts of traditional asthma that can help treat it, right? As well as traditional steroid inhalers. And then there's some on IL-4 and IL-5 as well. And then we've got this other side. So this was type 2 inflammation. This is traditional asthma. And then on this side, there's non-type 2 inflammation. This is this asthma that we're still learning about. And obesity falls under this side, okay? So IL-6 is that inflammatory marker that's released from the fat cells. And you can see how it's also here in asthma, and it exacerbates this Th17 cell and then creates more inflammatory markers, and it causes these increased neutrophils. And then here's that TNF alpha I just said that the fat cells release too. So these increased neutrophils are obviously impacting the airway and make it really hard for us to treat it. Right? It's a lot easier to treat this side with the eosinophils than it is the neutrophils. We don't have enough, you know, research on it yet. So anyway, this is how you get hyperresponsiveness, remodeling, and mucus production, and the problem with the smooth muscle cells. So like I said, on that one side, there was, you know, traditional Th2 inflammation, and then the other side, there's non-Th2. But so we actually have two different obese asthma phenotypes that have been developed. One is early onset asthma, and that typically happens with someone who is under 12. Male and female are equivalent in this section. It's usually atopic. Atopic means allergic, like, you know, allergic rhinitis, or eczema things are atopic as well. And then you see that severe decrease in airway function of that FEV1 and the FVC. So the FEV1 is the one that we test in the office every time that you come in and you breathe out in the spirometer for us. And that has significant airway hyperresponsiveness. And typically there's a higher symptom score. So people are pretty sick, but there's eosinophilic airway infiltration and the high Th2 biomarker. So what I was just explaining before, but this one is a little bit easier to treat. And then you got this late onset asthma that happens after 12 years old. For some reason, female is more than male. We're not sure why. It's non-atopic, so it's not necessarily related to allergies. And it's not too much airway obstruction. It's actually more restriction, like I mentioned. And then the airway hyperresponsiveness is not as much. There's lower symptom score. There's neutrophilic infiltration, like I mentioned, and then those low Th2 biomarkers. So there isn't the high nitric oxide or high eosinophils like there are in the early onset asthma. So we've got this two different types of obese asthma phenotypes that are happening. This is just another slide that is crazy. Don't worry about it, but it shows all these different fancy drugs that we have to treat asthma. And then this is the one I was saying, that IL-6 that comes from those fat cells. And there's some research being done on how we can block that IL-6 in severe asthma to help treat this severe asthma obese phenotype. And it's out there, but we're not, you know, it's not ready yet or anything. So basically, obesity has those inflammatory markers, the TNF alpha, the IL-6, other cytokines as well that I didn't mention, and we call adipokines, which means they're coming from that adipose tissue, but they worsen the airway hyperresponsiveness, and they can exacerbate asthma and even rhinitis. So one of the other things I said I was going to mention was insulin. So I did a whole presentation on how insulin is bad, and it's the fat storage hormone that's released from the pancreas, and it doesn't let you release fat. Well, it also promotes bronchoconstriction. So it, tightens up those airways, makes it harder to breathe. It can also lead to some deposition in the airway, causing airway remodeling and airway hyperresponsiveness. Now, we see that a lot in the office as well, kind of maybe someone who was a never smoker, but their breathing numbers are not so good and their asthma maybe wasn't controlled their whole life. So now they're having this, what we think is airway remodeling, because they can't get their numbers all the way back up to 100%. And it's interesting because even in kids with asthma, we're starting to see markers of insulin resistance. So high cholesterol, that's dyslipidemia, or acanthosis nigricans. That's basically darkening of the skin on the back of the neck or the armpits and things like that. And because, the Asthma Obesity Association and the fact that it's happening younger and younger, we're starting to see that in kids with asthma now. So obviously, we have to use systemic steroids sometimes to help treat our asthma patients. And unfortunately, that's one of the best treatments to keep them out of the hospital and to reduce exacerbations and keep them under control. The problem with systemic steroids or glucocorticoids is that they increase the level of cortisol in the blood. And the cortisol is, it's a stress hormone, but it also, we're giving you extra of it. And that alone causes weight gain, increased appetite, increased insulin resistance, increased risk of other metabolic conditions, and even musculoskeletal wasting effects. So basically, when you have too much cortisol going on, like if you're really stressed or you're taking this steroid, they can, you're basically starting to burn your muscle for fuel sometimes instead of the, glucose that you're consuming. So it's not a good thing that is going on, but it's very important that we keep people out of the hospital and keep them able to breathe. So we have to do it sometimes. And obviously we try to keep it a short-term use, a 10-day course, definitely using an every other day dosing if we have to do it longer, because that can significantly reduce the side effects. But the short courses aren't usually associated with weight gain. They might definitely carry some water weight. And if you are having an increased appetite, you actually are eating more, it could be associated with, but it's really mostly not associated with short-term courses. And then we try to avoid it, obviously. And that's why there are inhalers now. So high dose ICS, or inhaled corticosteroid, is also somewhat slightly associated with weight gain, but not near as much as systemic steroids. Pediatric subjects who have moderate to severe asthma on those inhalers are a little bit higher risk for weight gain. So we usually use the lowest effective steroid dose that we need to use to, reduce those exacerbations and not have to put on systemic steroids at all. But uncontrolled asthma itself leads to reduced physical activity and weight gain. So if we aren't using these inhalers or steroids as needed, like to reduce an exacerbation, the uncontrolled asthma itself is even worse. And it's, you're not going to be able to function. You're not going to be able to walk around or breathe outside or inside. And that alone is going to lead to weight gain. So we really, we're kind of a pickle using these medicines, but we need to use them so that it is not creating more exacerbations and hospitalizations and just reduced quality of life and ability to breathe. I did want to just mention briefly, I don't want to go into the details, but obstructive sleep apnea, or OSA, is strongly related to asthma. There's, been very detailed mechanistic way. And then it's also related to GERD or reflux, gastroesophageal reflux disease. They're all kind of interrelated and very important to treat one to make the other better and rule out, obstructive sleep apnea for someone who is not able to, lose any weight, because that can lead to increased blood pressure, increased cortisol levels, and all sorts of things. So I just wanted to mention that they're all related, but I'm not going to go into great detail today. So I just want to mention also like things that coming from the diet. I don't know if you've heard of an anti-inflammatory diet. Well, some foods that actually promote inflammation in the diet. So those are foods high in sugar, processed foods, refined grains, fast foods, diets high in red meat and saturated fat. These are all considered inflammatory foods, and they can also lead to systemic inflammation. So if you can reduce these, that's the best thing that you can do for your asthma and for your obesity. So foods decreasing systemic inflammation. This is going to be that Mediterranean type diet: fruits, vegetables, whole grains. Foods high in beta carotene, riboflavins, vitamins A, C, D, and E are associated with decrease of wheeze and asthma in both adults and children. So you definitely want to eat more of that. And then high fiber diets have been shown to help too. I'm not going to go into detail of what the free fatty acid stuff does, but it let me go to the next slide here. But yeah, so dietary fiber can affect the gut microbiota, which also has been shown to be different in obesity. It can inhibit allergic inflammation in the airways. So dietary fiber is always a good thing. So obesity actually results a lot sometimes from consumption of high caloric containing and low fiber containing foods. So that is why they think that maybe both are setting the stage for asthma and obesity development from these inflammatory foods. So consider kind of trying to focus on the Mediterranean pattern of eating and the low systemic inflammation foods. So what are some treatment options for the patients with asthma and obesity? Obviously, weight loss. It's one of the only modifiable risk factors for asthma. A high-fat meal can have an immediate effect on inflammatory cells as well as lung function. They showed a rapid decrease in that amount you breathe out in 1 second after a high-fat meal. They also showed the increase in the sputum airway neutrophils. So that's what I was just talking about, that patients with severe obesity and asthma have struggling with and make it harder to treat. And then I mentioned this earlier, but vitamin D levels tend to be low with elevated BMI and with elevated asthma severity. Higher serum levels have been shown to show a little bit more sensitive to the glucocorticoids, which is good because it means to be easier to help treat those people with the high vitamin D. Like I said, the Mediterranean diet is protective against asthma and allergic rhinitis. 78% reduced risk of having uncontrolled asthma in one study. That's pretty good. And then statins, if you're on a atorvastatin, simvastatin, rosuvastatin, they actually have anti-inflammatory effects, and they prevent remodeling of lung tissue and improve lung function. So if you happen to be on one of those for cholesterol, it could be helping your asthma a little bit too. And then, like I said, you want to treat comorbid obstructive sleep apnea, depression, GERD, et cetera, for improved asthma control. So what can weight loss, how can that affect your asthma? So basically, the asthma control and quality of life scores improve. It's shown to decrease airway inflammation. The decreased airway inflammation improves the lung function studies that I was mentioning. Patients with asthma and obesity after weight loss require less asthma medications. Patients who lose at least 20% of their weight have better asthma control. Weight loss decreases the risk of asthma exacerbations, resulting in decreased hospitalizations and ER visits. Rhinitis actually may improve as well as GERD and obstructive sleep apnea improve and resolve as you lose weight. And obviously, the reason why I'm bringing this whole subject up is because there's been more and more emerging evidence that's showing that there's a shared pathophysiology between asthma and obesity. And that's, really important to get under control so we know what to do and how to help patients with these conditions. That's all I have for you today. So these are my references. And this is how you can work with me if you have any more questions. And seriously, if you have any questions, please post them in the Clearwater Family Medicine and Allergy Facebook group or site, or you can make a comment on the YouTube video or anything like that. Just let me know. I know that was a lot to understand and grasp, and I didn't expect you to learn it all, but hopefully it gives you an idea that asthma and obesity are really associated, and we should be treating both of those things at the same time to improve both conditions. Thanks for listening today, and have a good one.